Thank you for having me back again. Unlike Helmut, I cannot do 3 talks in a row. Dr. Rinke is one of the only people who can do that, still have energy and carry it off okay. But I will do 3 talks. We'll just space them out. So the first thing we're going to talk about is IgA nephropathy. And IgA nephropathy is something that has been very popular in the literature recently. There are now controlled trials that on many different areas, and you'll see that some that are ongoing, some that have just been published, some that have come out that have confused the literature. We'll try to go through what's new with the pathogenesis, diagnosis, and treatment of IgA. These are my conflicts of interest. I usually put at the bottom that I have no major ownership or stock holdings in anything, which is true, but it's going to be the same for all of them, so I'll skip the slide in the future. So we're going to deal with just one patient. This is a 19-year-old white college student who has no past medical history. He develops dark urine while playing soccer with his friends. The urine clears, but the dark urine recurs again when he's running to class 2 days later. His local doctor checks him out. His blood pressure is 140/90, but he's a little nervous. He has no edema. His urinalysis has 3+ protein, 3+ hematuria, and red cell casts in it. The BUN is 18, the creatinine is 1, his urine protein is 2 grams per day. He gets referred to a nephrologist, one of you. He gets a kidney biopsy, shows IgA nephropathy with an Oxford classification of M0, E1, S0, T0, C0. So if you're not using the C's in there, you're going to be using them after today. So which statement is true regarding the epidemiology and pathogenesis of IgA nephropathy? A, the diagnosis of IgA nephropathy requires a kidney biopsy. B, IgA nephropathy comprises only 1% of all biopsies in the US, but 50% of all biopsies in Asia. C, the pathogenesis of IgA involves hypergalactosylation of the IgA1 molecule at the hinge region. D, healthy individuals and blood relatives of IgA patients have normal levels of galactosylated IgA in their blood. Which one of those is true? Should I try this? I think, I'll do it here. Multiple choice, right? Okay, and I wait till 50 people do it. And then I click it again. Good. Look at that. Okay, I figured if Helmut could do this, I can do it. Okay, so 55% of you are correct. It still requires a kidney biopsy. I'm hoping in the future that it won't, but now it requires a kidney biopsy. Let's go through the data on these. Now, how do I just exit out?
Click the X out.
Yeah, right there. Oh, good, great. Okay, so IgA nephropathy is defined by the deposition of IgA in the glomerular mesangium, sometimes along the capillary wall. As nephrologists, you have to remember IgA is either dominant or codominant. You can have as much IgG and IgA, they both can be 2+, and that can be IgA nephropathy. So it's either the dominant or codominant immunoglobulin. In young people, it presents like this: gross hematuria after a sore throat or after exercise, etc. In adults, much of the cases come because of insurance physicals, because of routine checkups where they find proteinuria, they follow the patient, and all of a sudden it gets to levels where you get a biopsy. It is clearly not the benign recurrent hematuria that Berger described. End-stage renal disease, 15 to 20% by 10 years, 30 to 40% by 20 years. There are risk factors for progression, which we're going to go through. And in terms of therapy, the most important thing is there's no single therapy for everybody. You have to look at the patient, you have to look at the risk factors and decide, will this person benefit from therapy with either immunosuppression or other medications? So this is the demographics of IgA nephropathy. If you look in native biopsies, it's about 5% of all the biopsies in the United States and about 10% of the GN biopsies. If you go to Asia, China, or Japan, it's 30%, 40% of the GN biopsies. So a lot of people feel that it's underrepresented in the United States. If we biopsied people with milder levels of proteinuria or earlier findings, we'd find a lot more. It's always one of the 4 top diseases we see at Columbia. Right now, they're processing between 5,000 and 6,000 biopsies a year at Columbia. They've got 7 full-time nephropathologists. That's all they do is just look at kidney biopsies. This is always in the top 4 diseases there. So again, a very common disease, regardless of whether it's 5, 10% of what we see. Now, if you look at the IgA molecule in people with IgA nephropathy, it has a low level. It's undergalactosylated at the hinge region of the IgA1 molecule. It's missing these galactose residues. That's important because it tells us something about the molecule, and it also tells us something about the whole pathogenesis, at least our current view of it. If you look at people, adults with IgA nephropathy, here in red, you're looking at patients who had the galactose levels measured in their circulating IgA, and you can see the majority of them have galactose-deficient IgA. If you look at blood relatives, you'll find exactly the same thing. If you look at controls, which are spouses, husbands and wives who don't have any connection here, it's very low. So patients and their relatives, their first-degree relatives, have an abnormal molecule. Now, this is also true for pediatric IgA. This was Ali Gharavi's study, who runs the renal division now at Columbia, and Christoph Kiriluk, you'll see his name again, does a lot of the genetics in it. But pediatric patients have the same thing. And patients with Henoch-Schönlein purpura have the same thing. They and their relatives have an abnormal molecule. So we think the current pathogenesis is people have an abnormal IgA molecule, which is probably genetically defined. They develop antibodies against this. They get antigen-antibody immune complexes, which land in the mesangium. This leads to proliferation, sclerosis, and damage. Now, you can say, why don't the family members get this if they have the abnormal molecule? Well, it takes something to trigger this. Something is triggering the production of the antibody. Maybe a virus, maybe something is triggering this that leads to production of the immune complexes, and most of the family members will never get the disease, but they have the abnormal molecule. There are 2 tests that we thought would turn out to be great in terms of being prognostic, and they may be, except they're not commercially available. They're very hard tests to do. One is measuring the amount of circulating galactose-deficient IgA1 in the circulation of these people. If you have very little of it, your kidney survival is great, even though you have IgA nephropathy. If you have more, and even more, your kidney survival is less and less and less. So yes, it does correlate with kidney survival. The more circulating galactose-deficient IgA you have, the worse off you are. But again, very difficult test. Likewise, looking for antibodies against the IgA, those anti-glycan antibodies, yes, if you have them, you have a lower kidney survival than if you don't have them. Now, the other thing that may help us in the future is genetics. So it turns out, even if you go back a number of years ago, there were a number of genes that were specific for IgA nephropathy. This is a study that Christoph Kiriluk did at Columbia using 20,000 individuals. So these are big GWAS studies that they look at. They found a whole series of new genes. So there are now 15 independent genes that are involved in IgA nephropathy that are not in the controlled populations, whether you look at people in the United States, in China, in Europe, in these different populations. The interesting thing is a group of these genes that light up are involved in mucosal innate immunity, which we think is what leads to the abnormal IgA. A group are involved in the immunity and antibody production and recognition of this antibody as abnormal. And a group are involved in tissue inflammation. So it fits with this hypothesis, which was partially developed after the genes were known. We still can only explain 10 to 15% of why somebody has this, a very small percentage, you think, based on genes. But more will come in the future. Now, what about the survival of patients? Getting back to what you can look at right now. This is taken from a study of over 1,100 Chinese patients with IgA. If you look at the survival, it's 83% at 10 years. The renal survival is 75% at 15 years. It's 64% at 20 years. Just progressive loss over time, but a slowly progressive disease in the majority of cases. Now, some of you may be sitting there saying, well, that's fine for a Chinese population, but what about other populations? So here's a more recent study from Japan, exact same curve. Here's an older study from London, the exact same curve. Again, people are losing function over time. It's more and more. So when you see somebody who's 25 years old, you have to think not about a few years, not about 5 years, but 10, 15, 20 years when you may not even be in practice anymore. What should you be doing now to try to prevent that person from progressing? So here's question 2. In our 19-year-old college student with IgA, which features independently predict a poor outcome in this patient? What is a poor prognostic finding? Episodes of gross hematuria. Guy had 2 episodes of gross hematuria at 19 years old. Proteinuria with 2 grams of protein in the urine. On biopsy, mesangial proliferation in 30% of the glomeruli and endocapillary proliferation in 40%. A biopsy with an M0, E1, S0, T0, C0. Now, you can't vote because I don't have that thing on the slide anymore, but it doesn't matter. Just write down, take your napkin and write down what you think the answer is here. Okay, the most important predictive thing, our best biomarker, is proteinuria, and much better than in any other disease. This is taken from the Toronto registry. Everybody in the city of Toronto who gets a biopsy, they all get logged in through Dan Catran's registry. Here's when they had 540-something patients with IgA. They're followed long-term. If you started with less than 0.3 grams, 300 milligrams of proteinuria per day, you did great. If you had between 300 and a gram, you did great. If you had between 1 and 2 grams, look at the fall off over time at 10 and 15 years. Here's 2 to 3 grams, and here's over 3 grams. Now just think to yourself, if that person had focal sclerosis or membranous, and you had 2 grams of proteinuria, you'd say, I'm doing great. This person's going to have a great outcome. But here in IgA, they have a bad outcome with just that amount of proteinuria. The other very important thing in this study that Heather Reek did with Dan was they looked at the patients and they said, if you started with any level of proteinuria, 1 to 2 grams, 2 to 3 grams, over 3 grams a day, if you started with any of those levels, but you brought it down, either through ACE inhibitors and ARBs, either through immunosuppression, etc., what was your outcome? The outcome was the same. They all did equally well if you reduced the proteinuria. So reduction of proteinuria is an important outcome in this disease, and a lot of people feel it's one that the FDA is soon going to approve drugs based on the reduction of proteinuria. And it doesn't take a lot of reduction here, you can see, to make huge differences. And I'll show this to you again later in some of the studies. Now, if we look at the pathology, this is a typical glomerulus with a little bit of mesangial proliferation, more than 4 cells at areas away from the vascular pole. But here's our IgA deposit in there. Obviously, you can have many different pictures on pathology, not just this simple one. The Oxford classification, which many people used to call the MEST classification, looked at mesangial hypercellularity, endocapillary proliferation, segmental glomerulosclerosis, and tubulointerstitial fibrosis. I want to point out a couple of things. First of all, you only get a 1, and the higher your score, the worse you're doing. You only get a 1 if you had over 50% of the glomeruli involved with mesangial hypercellularity. So if this kid had 30% involved, he gets a 0. He doesn't have an active lesion in terms of that. The others are absent or present. Very important, tubulointerstitial fibrosis is the only one that's weighted 0, 1, 2. The higher you are, the worse you do, and you get up to the 2s there, you're in trouble. Now, that was pretty easy because everybody could remember MEST. But unfortunately or fortunately, now there's a C thrown in, and it's unpronounceable. You can't say MESTC and say the MEST class. There's no way to pronounce it. But in any case, crescents matter. They weren't studied in the original classification. Here, you're looking at a review of 16 studies, over almost 4,000 patients here. 570 went to renal failure. Looking at if you had a higher score here, not 0, 0, but 1 or 2 in any of these, including any crescents here, any crescents, it was highly significant. The E was the only one. Endothelial proliferation was not. Endocapillary proliferation was not in there. And the reason that it wasn't in there is that if you treat the patient, it wipes that out. So in this kid's biopsy, his MEST score is very good. He had 2 grams of proteinuria. The proteinuria is the thing that's really the problem. Okay, validation of this score. So here you're looking at 1,100 plus patients, 13 centers. This is the Valiga study here. I want to point out a few things. MEST was still an independent predictor of GFR and survival. If the GFR was very low, the mesangial proliferation and the tubulointerstitial fibrosis were still important. And most important, we all think about this, if you have over a gram of proteinuria, we're going to do a biopsy. Except in the Valiga study, if you had less than a half a gram, you did better than if you had a half a gram to 1 gram. Later on, you'll see when we talk about the STOP IgA trial, the German trial in the New England Journal, they used 750 milligrams of proteinuria. Maybe we're biopsying these people too late in the United States because the evidence is you can make a difference even at 500 milligrams of proteinuria, certainly less than a gram. So, which is true about the treatment of this patient? Since he's only 19 years old, he'll benefit from tonsillectomy. He should take 3 grams of omega-3 fish oils for the rest of his life. He should take an ACE inhibitor or ARB to reduce both blood pressure and proteinuria. Given a urinary protein of 2 grams a day, he is unlikely to respond to a 6-month course of tapering steroids. Okay, now think of what you would say here. I don't have those little things, but I don't need them. We'll just, people are starting to look at me. They look hungry, they're ready for lunch. I can't keep going on with this. Okay, so let's see the answer to this. First of all, there are 24 different studies that have looked at ACE inhibitors or ARBs in IgA nephropathy. 4 are inconclusive, 20 are positive in terms of in favor of using them. This is Manny Praga's study from the Spanish Glossin group. If you look at 50% increase in serum creatinine, if you're on renin-angiotensin-aldosterone system blockade, you have a much lower percentage that have an increased creatinine than if you got a placebo, which is other antihypertensives. So again, it worked here. If you look at Rosanna Copo's stuff, same thing. In Italy here, you're looking at progression. This is survival here, that if you have the ACE inhibitor added on, you do much better than if you have the placebo or other antihypertensives. So that's clear cut. This young person at 19 should definitely be on an ACE inhibitor or an ARB. What about tonsillectomy? So this is the study that everybody refers to. Patients come into you and they say, well, I think I should have my tonsils out. And they said, but you already had your tonsils out. You can't have them out twice. But anyway, they don't, you can't even see the tonsils in somebody who's 50 years old. But they looked at this study. It was in Kidney International. It was a good looking study. Tonsillectomy, it's retrospective. Tonsillectomy in 48, no tonsillectomy in 70. You look over time, the tonsillectomy group did better. Now, how long did it take for the tonsillectomy group to do better? This is not days, this is months. So this is 10 years here. The curves don't even split at 10 years. If you have a guy who comes in with 2 grams of proteinuria, he's going to be in renal failure unless you do something before that. You can't wait 10 years taking out his tonsils. Maybe if somebody, says, look, I really want to do it, and you can think of 20 years out. But again, and if you look at all the studies that were done, you can see the meta-analysis shows there's no real benefit. So most groups do not, KDIGO didn't recommend it, most groups do not recommend tonsillectomy unless somebody has bad tonsillitis. If they do, fine. Then there's no reason not to take out the tonsils. So that was left from the old KDIGO, but the new KDIGO agrees. Now, what about fish oils? So that's the other thing that patients and their families always come in saying, you know, I already have him on fish oils like this, and he hates taking the fish oils, whatever. And of course, there are good fish oils and bad. There are the omega-3s, the eicosapentaenoic acid and the docosahexaenoic acid. And then there are the cyclooxygenases and lipoxygenases, which are bad. So what are they actually getting? Well, you know, some people say, well, wait a minute, you know, I'll just eat a lot of fish. Well, you could eat a lot of fish, but how much fish oil, how much omega-3 fish oil is there in fish? So if anybody is here from Amsterdam, herring is loaded with it. So if you're eating a lot of herring, you know, you're getting the fish oils you want. But look at salmon. You can see Chinook salmon has a lot, that sockeye salmon has almost none. Now, who knows what kind of salmon? You know, even if you go into a good restaurant and they say it's wild salmon, they found out when they analyzed it in New York, most of those were farm-raised anyway. So they don't even know if it's wild, let alone if it's, the only place in the United States is either, you know, Seattle, Washington, or Alaska, where they tell you, you know, the king salmon's out at Seymour, it's fatty or whatever. The waitresses know all that. And if you think you're getting your fish oils from tuna fish, all you're getting is mercury. There's no fish oils in there at all. So, you know, the problem is, if you go to a health food store, look at the difference here in these capsules, you know. So what are they actually getting? So if they want to take fish oils, yes, but don't replace the ACE inhibitor or A or B with fish oils. Now, this is the best of the studies. So this was Jim Donadio's studies from Mayo Clinic. He did a couple of them using Omicor, which was all omega-3 fish oils, and you can see here the percentage who did not have a 50% increase in creatinine was much better. Treated them for 2 years, but the curve stayed out here out to 8 years in terms of that. But there are equally good studies that didn't show that. Here's a study that we were part of looking at 100 relatively young people, less than 40, GFR preserved. They all had IgA. They all had over 0.5 grams of proteinuria. 33 got every other day prednisone. 33 got omega-3 fish oils, 31 got placebo. These are the treatment failures, the creatinine rising up. 2 of the 33 in the steroid group, 8 of the fish oil group, 6 of the placebo. There was no way that the fish oil group was going to catch up, so it wasn't beneficial there. So again, controversial data. It's better to say, take your ACE inhibitor, take your ARB. If you want to take fish oils, fine. You know, but again, the evidence is weak. Now, what the evidence has not been weak for is steroids. If you look at a 6-month course of steroids at any dose, tapering dose, the first studies were done by Pozzi. He followed them out where he had 10-year data on everybody. Then there was a Chinese study that followed this, then another Italian study. Now, the criticism of Pozzi's study was that only 40% of them had an ACE inhibitor ARB, because those studies started a long time ago. But that being said, 21% of the people in the steroid group had progression, 33% of the controls. In this Chinese study from Peking #1 hospital, good hospital, here everybody got an ACE inhibitor. They all got cilazapril. 3-year kidney survival, 96% in the group that got the steroids for 6 months versus 66%. Now, of course, everybody complained, well, we don't have cilazapril in the United States. We don't even know what it is. It's an ACE inhibitor. But so the study was done, Mano study, used ramipril. The progression here, 4% of the combined group that got ACE inhibition and steroids versus 26% that got ramipril alone. And everybody got ramipril. So these are 3 pretty good studies that suggest they're all controlled. There are not huge numbers in any of them, but they all showed that a 6-month course of steroids, and I'm not telling you what the course is because, again, it's different in every one of these studies, whether they use a pulse, whether they use a pulse each month, but it's 6 months of tapering steroids. This is just the endpoint of the Mano study here, where everybody had over a gram of proteinuria, GFR over 50, almost 100 patients here, end-stage renal disease at 8 years here, 1 of 48, 8 of 49, 8-year renal survival, 98%, 70%. Again, everybody is on ramipril. One other study that's worth mentioning, steroids in the Valiga trial that I mentioned before. They looked at a nested propensity matched case control study, 184 pairs, of which they're matched for almost everything. One group had steroids, one group did not have steroids. Steroid usage had a superior outcome, even if you looked at GFR, different groups of GFR, and different amounts of proteinuria. So, benefit of the steroids over ACE inhibition alone, whether you had a low GFR or a high GFR. Again, concurrent with the other studies, and a difference in GFR loss and a difference in proteinuria as well. All positive. Now, I'll come to the STOP IgA trial in just a minute. I just want to mention other immunosuppressants briefly, because there are two older studies. One, the Ballard-E trial, used 3 months of cyclophosphamide followed by azathioprine for a number of years. The treatment group did great. The control group did terribly. Here's 5 years. At 5 years, everybody in the control group was in renal failure. Now, that's a UK study, and nobody in the UK believes it or uses that. So you say, well, why don't they use it? Because their controls don't go to renal failure that fast. So there's a problem with that. The other thing is POTSI followed this with an azathioprine trial. Steroids plus azathioprine versus steroids alone. The curves are identical out to 7 years. So azathioprine did not add anything to treating with steroids. Keep that in mind when we come to the next studies. So here's the STOP IgA trial. And as I said, we're getting more and more trials here, but it's not necessarily clarifying things, though it could be. So here's a large trial that has control data, but it's how you interpret the results that make the difference. There we go. Okay. So first of all, they enrolled 337 patients. However, by lowering the blood pressure and following to get them into the study, only 162, less than half of the patients enrolled, were actually randomized to get a 6-month course of steroids or to get cyclophosphamide followed by azathioprine and steroids. So again, if your GFR was low, they used that Ballard-E regimen. If your GFR was above 60, you just got prednisone every other day for 6 months with pulses like the POTSI regimen. Their definition of remission was very rigid. Their definition of progression was just a well-conducted study. But if you look at the endpoints, remission of proteinuria, there's zero doubt that the immunosuppressive group did better. If you look at progression to renal failure or progressing over time, there were no differences. So again, given that it's a very select group, these are people who still had proteinuria after maximal ACE inhibition, they got the blood pressure, you had to get your blood pressure down to 120/80 or less, very honed in group here. You're finding differences here. Here again, remissions significantly higher in the immunosuppression group, but no higher here in progression here in this group. It's the same. So the author's conclusion is, and there was no difference in the co-primary outcome. There were more adverse events. There were more infections in the group that got the steroids as well as getting the ACE inhibition. The estimated GFR loss was much lower than expected. It was way down in this group, and supportive care makes a major difference. And I don't agree with any of those here. But many high-risk patients do respond to supportive care. And again, in terms of proteinuria, it goes down. And we know that getting the proteinuria down to back what it should be, or what it was originally, down to 1 gram or something from Dan Catran's work, makes a difference in outcome. And the progressive loss of estimated GFR still occurs in a fair group of the patients. So I don't think there's differences in the data. It's how you interpret the data here. I would interpret this as a positive study. Jürgen Flege interprets it as a negative study. But again, I think this is concurrent with the other data in the literature. Now, the other trial that has given us some controversy is the testing trial. The testing trial was published in JAMA in 2017. It was a trial of using oral methylprednisolone versus placebo for 6 to 8 months. They used a big dose of oral methylprednisolone. 262 patients here that the primary endpoint was end-stage kidney disease, death, or 40% loss in GFR. It was stopped early. Too many side effects in the steroid group. So if you look at this, here's significant adverse events were clearly higher. Serious infections were clearly higher. Now, half the study, more than half the study, was in China. It was China and Australia, but a lot of the patients were in China, and they were left on a high dose of steroids for a long period of time. But if you look at proteinuria, it was significantly reduced with the steroids. The composite endpoint, renal endpoint with renal failure in there, was 1/3 the level if you took the steroids. End-stage renal kidney disease, again, 8% versus 3%. So it's not statistical here because the numbers are small, but these are statistically significant. So again, there's evidence that steroids do something. You just have to make sure you don't toxify the patient. And they are redoing the testing trial, but they're doing it with closer monitoring and tapering down a lower dose of steroids now. And here you can see methylprednisolone doing better at the primary endpoint, not going to renal failure. GFR is better, and proteinuria was further down. Now, just a few more things on therapy. Mycophenolate. This comes up again and again because mycophenolate has been used in a lot of proliferative glomerular diseases, lupus, etc. We'll talk about that this afternoon. So what's the role in IgA? So if you look at 4 studies that were done that we found in this one, we were doing it for the National Kidney Foundation. We were going to enroll 100 patients. We actually stopped at 40 and published the results in 32. We took in patients whose GFR was very low. We shouldn't have done it. That they all started to progress. You need to have a higher GFR to start. But the 2 studies that are very comparable was Mises study from Belgium and Tang study from Hong Kong. If you look at them in terms of numbers, the dose of mycophenolate, the estimated GFR, the proteinuria, blood pressure, everything is the same. The follow is a little longer here. The Belgian study came out negative. Tang study from Hong Kong came out positive. So if you look at this in Tang's study here you're going out 72 months. The mycophenolate had a much better rate of dialysis-free survival. What is the difference? It's not clear. Is it because it's a different population in Belgium? It maybe the biopsies are different, maybe even though they look like they're read the same. We don't know. All we know is some studies, again, have been positive, others have been negative. There is one more recent study, which I gave you more data in the syllabus on. It looks at mycophenolate and very low dose steroids versus a full dose of steroids. And what they found was the results were exactly the same if you followed them out over a year. Adverse events were the same, but getting cushingoid in the high dose steroid. Diabetes, much higher in the high dose steroids. Infections were about the same though. So again, this suggests there may be a role for mycophenolate, maybe with lower dose steroids. Again, it's not the first line drug, but as a backup. Now, where are we going with newer therapies? I'm not going to talk a lot about newer therapies that I don't think are going to come to fruition because it's not worth your knowing, but I can talk about things that are likely to succeed and that have already succeeded and just out in abstract form. So budesonide we'll talk about, a non-absorbable steroids. We're not going to talk about atacicept or the APRIL-BAFF inhibitors because they just halted this study a matter of weeks ago. I'll talk about ACTH, hydroxychloroquine, that's Plaquenil, anti-B cell therapy. I'm not going to talk about blocking the complement pathway because, again, it's too preliminary. So the Nefegan trial was published in Lancet less than 2 years ago. 150 patients, 62 sites, that 10 European countries, double-blind study here. They looked at 2 different doses of this non-absorbable steroid. Now, this is an FDA-approved, budesonide is FDA-approved in the United States for asthma and colitis. It's not approved in this preparation. This is a modified preparation, but it should not be absorbed. It should be gone on first-pass metabolism through the liver. In any case, here's proteinuria with placebo, Here's low-dose budesonide. Here's high-dose budesonide. A positive study here, again, with very few side effects, presumably not absorbed. The current study, the NefIgArd trial here, will have 450 patients. This study is undergoing right now. It's an easy study to get patients into, because again, if they failed other things, as long as they're far out from steroids and other things, they can get into it. It'll be 450 patients. If they can reproduce that drop in proteinuria, this will be approved. And it's easy to get patients to enroll because you say, this is budesonide. It's a different preparation, but there is another preparation that's already FDA approved. What about rituximab? We did one control trial in rituximab that was negative. It was only about 50-something patients here that we did this at Columbia with Brad Rovin and Rich Lafayette and Fernando Fervenza, the usual suspects here. In any case, if you look at estimated GFR, no different than control. Drop in proteinuria, no different than control. But again, it was a group here that had a creatinine of 1.5. The proteinuria was significant in this. Maybe it was the population that wasn't right. Does it mean rituximab will not work in anybody? Well, it didn't work at a year in these patients. That's all we could say. Hydroxychloroquine, which actually I had hardly thought of this as being used, but this is a placebo-controlled randomized trial that was just published. 60 Chinese patients with IgA, everybody's on an ACE inhibitor or an ARB here. Here you're looking at 50% reduction in proteinuria. Here's the hydroxychloroquine group. This is one of 3 studies that have been done with hydroxychloroquine, which are all positive. Now, 2 of them are by the same group. So, again, you can't, say maybe they're biased in terms of this. There's a nice editorial by Jürgen Floye that goes with this. This might be a simple thing to add on to your patients. Nobody's too worried about using Plaquenil in lupus patients, even during pregnancy, etc. So again, this may be an add-on that we can think of doing here, that it just, so far, this is the best of the 3 studies, and this isn't a great study either, so we need a little bit better data on this. And ACTH. This is the data from the abstract at the ASN. The paper's already in press already, so that'll come out. But essentially, looking at a group of 20 patients, open label, everybody got the Acthar, the ACTH. There were no complete remissions. There were 8 partial remissions of these patients here. And if you look, here's the albumin, which came up, and the proteinuria came down. But it's not a huge difference. The question is it worth taking this for 12 months or 18 months or whatever you're going to take, a very expensive drug that to raise your albumin from 3.8 to 3.9, to get your proteinuria to go from 2.82 to 1.97? That is not clear at this point, but there are some positive results in this. The paper will come out. We'll be able to analyze it. I got this from Pietro Canetta, who's our representative in this study. So as a backup thing, it's there. So what's my therapy for IgA nephropathy? Everybody gets an ACE inhibitor or an ARB, one or the other, as long as they can tolerate it. I strongly consider using a statin. Again, heart disease is the big, and cardiovascular disease is the big killer in kidney patients. This is a long-term issue in terms of this, as long as their LDL is above 70 or something, I'm in the range where I think it's probably worth treating them. I don't tell them to go on a no-protein diet, but I lean them towards a lower protein diet, which is not a high protein diet, because, Americans eat a ton of protein. So, it's nothing for, an American diet to be like 100, 120, 150 grams of protein. So I just tell them smaller piece of steak, smaller piece of fish if you're doing your salmon or whatever, that, lean towards fruits and vegetables. The blood pressure, certainly less than 130/80. Many less than 120/80, but it is very hard to achieve without having people dropping out and fainting. The last thing you want to do is put your patient on enough of an ACE inhibitor, ARB, and a diuretic that their blood pressure is down at 110/60, and then they go out and drive their car and get into an accident or fall when they're crossing the street. So again, what was achieved in one place is not necessarily achievable. 130/80 would be fine. Tonsillectomy, if they had bad upper respiratory infections and tonsillitis. Fish oils for those who want them. They should not replace other therapies in terms of fish oils. Again, the data just is not that strong that it makes a difference. Now, if you have mild disease, a normal GFR, your proteinuria is less than a half a gram a day, and you have a good-looking biopsy, that's it. I wouldn't do anything different. You're in a good group at this point. You can follow that patient. New studies are coming out all the time. As I said, we're working on all these newer agents to treat the disease. It's not worth even giving you a course of steroids at this point. If you have moderate or severe disease, a low GFR, proteinuria, I put down 0.5 to 1 gram. I used to have 1 gram there, but now from the Valiga data, from the data that the STOP IgA trial looked at 750 milligrams, not a gram, I think we probably should say between 500 milligrams and a gram. If you're in there, or your biopsy has bad-looking features on it, because that's an independent risk factor. If you have an MESTC score that's bad, you should be treated. I would use steroids in these patients. We usually use alternate day tapered. So by 6 months, they're down to 40 milligrams every other day, and it's a pretty rapid taper that they get. But again, very few people get cushingoid. They all tolerate the dose. We use that for 6 months. But again, you could use any of the regimens here. Watch for infections, watch for side effects. You don't want your patients cushingoid. You don't want young people with stretch marks that aren't going to go away. We rarely see these with the every other day regimen. You could use MMF with low-dose steroids. You could think of ACTH or budesonide, but again, the preparation that they're using is not the asthma preparation. So, using and saying, look, I'm not going to wait for the study may be wrong. If they have crescenteric glomerulonephritis with IgA, now I added this on, this is not in your syllabus, because one of the most common mistakes is you get a biopsy with IgA and it has 2 crescents on it out of 20 glomeruli. That's 10%. Well, again, if they're small crescents, that it probably is insignificant. A lot of IgA biopsies will have 1 or 2. If you ask pathologists what is crescenteric, they say 50% crescents. Well, if you had 40%, 30%, over 25%, I think everybody would treat that patient the same way, regardless of if it's a true crescenteric. If it's 5% or 7% or 10%, probably not. But for those patients with bad crescenteric, steroids and rituximab or steroids and cyclophosphamide. And if somebody has a high creatinine and the biopsy is loaded with chronic damage, glomerulosclerosis, and especially tubulointerstitial fibrosis, if they have a T2 on there, you've got to think twice. Are you going to use immunosuppression, or is it better just to back off at this point and say, look, we'll save the immunosuppression when this person gets a transplant in the near future? So this is a very important disease. I mean, the first time I saw this was up in Maine about 10 years ago in the supermarkets. It's the International Grocers Association. They're all over Australia and a lot of foreign countries. They've moved all the way down to Westchester in New York. I mean, we have stores on the top. But every time I see this, if I see IgA singles here, I'm thinking of IgA nephropathy. What can we do to help our patients? And now we're getting the advertising we need all over the place. So I think I'll stop here. Thank you.